On behalf of the American Heart Association's Certified Care Team, we would like to welcome you all and thank you for joining today's webinar, Impacting Stroke Outcomes, the next step for skilled nursing facilities in the stroke system of care. We want to thank you for joining us for a model share, the development of a stroke rehabilitation program at a skilled nursing facility, the journey to become the first certified in the United States, and the impact for patients and all care organizations along the continuum. My name is Steve Dental, and I'm the host for today's webinar. Some housekeeping reminders. All microphones will be on mute throughout the presentation, and you can, and we encourage you to submit questions through the Q&A button on your screen. Technical questions will be addressed as they come in, and we encourage you to submit other questions as they will be answered at the end of the presentation. Today's presentation recording will be made available after the webinar via email to all who registered and will be housed on the webpage. Before work that went into developing this certification that will be shared. Through the generosity of the Helmsley Charitable Trust, we actually began this journey roughly 5 years ago. With the guidance of a group of national experts and being vetted through actual sites, we first developed standards to guide all post-acute on delivering stroke rehab care. And then that was transformed specifically for a certification for skilled nursing facilities. We kicked off the certification last year with an announcement at our International Stroke Conference and a webinar last April. Special congratulations to Marquise Mount Holly facility and all their staff that made this happen. They were certified December 17th. We also have another 20 plus facilities contracted and working through the certification process. At this time, I want to introduce our speakers for today. Dr. Tracy Harris, lead physician with Virtual Medical Group, and Dr. Yogesh Varoja, chief medical officer with Marquee Health / Clinical Care Consulting. Dr. Harris is a highly experienced physician specializing in physical medicine and rehabilitation with a career spanning over 3 decades. She currently serves as the lead physician for Virtua Physical Medicine and Rehabilitation and as the program director at Select Specialty Hospital in Willingboro, New Jersey. Dr. Harris is deeply committed to patient care, focusing on acute inpatient rehabilitation for individuals with complex medical needs such as stroke, spinal cord injuries, ventilator dependency, and general debility. Her leadership and clinical experience ensure comprehensive rehabilitation management across diverse settings, including acute care hospitals and subacute facilities. She's a graduate of the University of Medicine and Dentistry of New Jersey, now Rutgers Medical School, and an Alpha Omega Alpha Honor Society inductee. Dr. Harris also completed her residency at Temple University Moss Rehab Hospital, where she served as chief resident. Her extensive professional affiliations, board certifications, and administrative roles highlight her dedication for advancing rehabilitation medicine while fostering patient-centered care and program excellence. Dr. Varoja is a board-certified internist and geriatrician with extensive experience in all aspects of clinical care and management of the clinical care for the geriatric population. He is particularly interested in geriatric care of community, helping with care and care models so people can live life with dignity, quality, and to the fullest extent. Dr. Varoja likes to focus on resident and patient-centered care, subacute and long-term, as well as population health at facilities. He believes in promoting wellness, prevention, chronic disease management, and assisting during acute illness recovery through specialty care services, service line at long-term and subacute facilities. So at this time, I'm going to turn things over to Dr. Varoja. Thank you so much, both of you, for being here.
Thank you, Steve. Good afternoon. Thank you for joining us today. Today, we are going to talk about stroke. It goes without saying, stroke has a devastating impact. And I'm here to share with you how to transform care delivery to improve the post-acute stroke care in our centers. Marquee is a progressive company with progressive variety of specialty program. Most recently, we decided to get first and foremost certification in the country for the stroke care in the post-acute when American Heart Association announced. And I'm very happy to share with you why we decided to do that and how we decided to achieve first out of all 15,000 nursing home certification for the post-acute care at Mount Holly, New Jersey, one of our premier facility. So what I want to share with you today, problem statement. We wanted to understand what the problem. We wanted to share with you the stat and facts. And then we're going to talk about some gaps, opportunities, and challenges as it relates to stroke care. After that, and I'm going to share with you our strategic analysis, strategic approach to develop a stroke program, and then partner with American Heart Association and apply and earn our first certification for the stroke. I'm going to partner with Dr. Tracy Harris, who is our lead at Mount Holly for our stroke program, and she's going to share with you her part of rehab care. Next slide, please. So let's talk about the problem. In last 50 years, we have made significant improvement in the health and healthcare. Having said that, stroke is still a leading cause of the long-term disability. We all know the risk factors: high blood pressure, cholesterol, smoking, obesity, diabetes. Look at the extent of these risk factors. 1 in 3 of us have one or more of these conditions. This gives us the understanding of the risk factors, how we are vulnerable for this disease. Aging obviously is another, and aging, there is nothing we can do. However, stroke can happen at any age, even though it is more common in elderly people. Let's talk about healthcare system. We talked about significant improvement in last 50 years. However, today's healthcare system is still not equipped to manage effectively, and we are not able to cope with this disease burden and its devastating impact. So let's look at the positive. As we look at the solution, skilled nursing facility are in the unique positions to help improve the stroke care by fundamentally changing the care model. And bottom line is fundamentally changing the care model. For that reason, we need to have a sense of urgency. We need to have sense of urgency, not only to improve care quality, but outcome of the stroke and helping people's life. Next slide, please. So let's talk about statistic. So 1 in 6 deaths from cardiovascular is from the stroke. Every 40 seconds, every time we will change this slide, somebody will have a stroke. And by the end of this webinar, in 1 hour, 18 people will die from the stroke. Around 800,000 people, to be exact, 795,000 will have a stroke in 1 year. Out of that, around 600,000, the first episode, and 185,000, that is 1 in 4, will have a second or beyond second episodes. Let's talk about the cost. 5 years ago, cost was $56 billion, huge cost. And this cost is because of the, not only from the healthcare services and medication, but also from the people's life who are missing work. This is a huge gap. So stroke is leading cause of long-term disability. It changes people's life. It changes families' life. Next slide, please. Let us try to understand this stroke spectrum. Obviously, initial insult is huge, happens within few seconds to few minutes. And over the period of next day, most people end up in the emergency room. Rapid workup is being done. Over the period of next 2 to 7 days, there is inflammation, scarring, and neuro remodeling happens. And as the time progresses, there is an endogenous plasticity. So what it means that neurochemistry, neuroanatomy, and impact on the brain and its function, it starts to improve. And this improvement of impairment and function continues all the way up to 6 months and beyond. Next slide, please. Let us understand the stroke. What does it leave patients with? 50% of the people will have one side of weakness. 35% people will suffer from depression. 30% of the people are not able to walk without assistance. 26% will need help for ADL. 1 in 5 people will have some aphasia. 26% will end up in the nursing home at some time for unknown length of time. Stroke is a major cause of hospitalization in the Medicare populations. Many survivors will require longer duration of the time, and 1 in 10 person will end up in the nursing home forever. Let's talk a little bit about TIA. The 90 days following TIA, 3 to 17%, from between 3 and 17% people will have a stroke. This is a huge red flag. More ominously, 1 year mortality post TIA is 25%. This is a huge risk. Next slide, please. Now that we understand the spectrum of the stroke, I want to share with you 3 things. What challenges our nursing home faces. First and foremost, as you know, there is a risk of recurrent TIA or stroke, around 3% incidence. However, in the immediate 30 days, it is more than TIA and recurrent stroke that patients could suffer. Impaired mobility related complications such as fall, pressure ulcer, bowel and bladder complications, urinary tract infections, pneumonia, likely aspiration pneumonia, risk of deep vein thrombosis, spasticity, shoulder displacement, and all contracture related issues, as well as the painful musculoskeletal conditions. These are the things bound to happen over the next 30 days to 90 days up to 6 months. Also, optimizing post-stroke care, including physical, cognitive, and psychosocial, is a huge complex takeover at nursing home level. And last thing, our job is to do a secondary prevention, and we need to work on all this risk factor we talked about. Next slide, please. Marky, I just want to walk you through our history. 10 years ago, when DRG was there, patients were staying in hospital only 3 to 4 days and being sent home. We decided to be disruptive and be the preferred partner for these people who are going home. 1 in the 5 people were coming back to the hospital rapidly. We took that opportunity. We started with pulmonary program. A couple of years later, we added specialty program and then renal program. During our COVID time, we decided to work with American Heart Association and earn their heart failure certification. We have around more than 35 facilities which are certified by American Heart Association. Now that we learned that American Heart Association is offering stroke certification, we wanted to be the first one. We took that challenge. So I'm going to share with you what we did and how we achieved this prestigious certification. And then I'm going to ask Steve to share what are the benefits. Next slide, please. We decided to do care analysis when we were working on the stroke program, and we asked ourselves five questions. Answer that we wanted to create a value to our customers while working with our employer, while working with our partners, stakeholders, and while working with our community. We wanted to create value in the society, which is a bit unusual. Traditional approach is not working out. We wanted to be useful in a way so that we don't need to say anything. Our action should speak for itself. And we wanted to create a business model that is creditable. So people need to feel that we are here to do something good. Even though it is not our primary goal to make this world a better place, ultimately we do believe that anything and everything we do, we want to make world a better place as it relates to all this acute diseases, living impactable, life-changing event of the people's life. Next slide, please. So for that respect, as we were planning to do things, we decided we need to touch this 5 point to create a stroke program. There is wide variation in the way we think about care and we provide care. We wanted to improve efficiencies and outcome at the right cost. We wanted to align with the communications and collaborations. We needed to do we needed to promote the culture of excellence. So our core value is all about patient respect and excellence. And we wanted to align not only with upstream, our hospital partners, but with the downstream partners, because this is a one spectrum, one disease, and we are one team. And we need to think alike as a one team so that ultimately, we do the best to improve the quality of people's life. Next slide, please. Okay. So we decided to put our plan together, and it is pretty simple if we do things right. Okay, this is what will improve the clinical care and outcome. Coordination of the care is so important across all conditions, across all healthcare providers, and across all healthcare settings, whether it is a ER, hospital, post-acute facilities, or at home with visiting nurse, or people living in assisted living, independent living, or with family or independent. More important is to use knowledge about patient, with the patient, and with the provider in a right way. So knowledge sharing is very important. We wanted to also apply evidence-based medicine. So whatever we want to do, we need to have some guidance and best practices. And next thing, education. Education for the patient is a huge thing. Patient needs to own this disease and recovery. People and family need to support the patients. They need to comply for the secondary prevention. And last but not least, what we learned from American Heart Association is we need to look at our own, how we are providing quality care, and we need to develop our own QAPI. Next slide, please. As we continue to put our plan together, I am a fan of Donabedian model. It is very simple. There are 3 parts: structure, process, and outcome. Think of a structure, think of a context in which the care is delivered, as well as the both provider and patients in the healthcare system act. So for that reason, we need to have right infrastructure, physical facility, particularly rehab space. We need to have right equipment, and more importantly, right people to provide care. We need to educate them, and we're going to talk about that. Second part of this model is process. The process is the sum of all actions that makes up the healthcare and care delivery. So all the touch point about whether diagnosis, treatment, prevention, early identification, intervention, educations, they all need to be right. And this is how we will create a quality of care. And last but not least, outcome. Outcome ultimately is the reflection of what we did good to the patients. How did we help them changing their health status, their behavior, their knowledge, their satisfaction, and quality of life. So based upon all our analysis, we decided to work on to developing a stroke program. Next slide, please. Okay. Pretty simple structure. We have been using for last 10 years, first 5 point. Our specialty program has a fundamental program management component, personal education with our facility, which includes both licensed and non-licensed staff. Patients and caregiver education is key part of our programs. As we get to the really granular level, care coordination, as I mentioned, across the board, clinical management, 80% of the whole spectrum. And finally, what we learned from the American Heart Association again is to look how good we are doing and where we can get better. And we added that performance improvement for disease specific, not just the QAPI at facility, but the disease specific. So I'm going to elaborate each of them in next few minutes. Next slide, please. Okay. Our mission as it relates to stroke. Our mission as it relates to stroke is to help achieve functional, psychological, and social improvement while working with rehabilitation intensively and changing the lifestyle. So our goal is at the same time to work on stabilizing, slowing, or reversing acute medical problem and comorbidities. That's our mission. Our vision is to improve the quality of life and allow people to have a better ability to deal with the disease. Our goal is to slowing patients' progress from the disease, improve their rehabilitations, and also let them own the recovery as they go home. And we wanted to create a patient-centric care. Each patient with each stroke is different, and we really need to work around that. So we wanted to create a value. As I said, we wanted to create disruption. So our differentiation in the care model is to create a balance in care. We wanted to improve care quality. We want to have a better quality, superior outcome while managing cost. And we wanted to work with all three partners: patients and family, hospitals, payers, as well as the populations. Next slide, please. Let's elaborate on all 6 pillars. Program management. I'm going to share with you our model. Next slide, please. Our model is pretty simple. It has not pretty much changed over the last 10 years. 4 different arms. Medical arm, we want to take care of the primary disease, which is stroke. We want to manage comorbidities. And we also want to stay alert about all prevention. We talked about so many complications, and usually things get worse about all complications within first 30 to 90 days. If things should happen, we want to identify in the right time, and we believe hospital at home, we believe treat in place, and we want to intervene as best as possible. Rehab, I'm going to let Dr. Harris speak about that arm. Education is very important for this devastating disease as it relates to primary disease process, how to manage comorbidities for secondary preventions, medications, all these little white pills we want to educate. And last but not least, diet is very important and sometimes misunderstood. Not only all these things are important, but what we call today social determinant of health is a very important part of this recovery process. We need to understand people, who they are, what kind of life they live, what kind of social support they have, what kind of psych management or psych support they may need, what kind of post-discharge management they will need. This is the model that is the reason for our success in last 10 years across the board, and I'm very proud of this model. Next slide, please. Okay. Let's talk about personal education. Ultimately, it is our staff who will provide the care. Next slide, please. 15-point educations for all our staff is so important. Is everything we want to do during our stay of our resident, whether it's about care delivery, change in conditions, medications management, rehab part, dining, patient safety, social determinant of the health, process and outcome metrics monitoring. Everything is very important. Every single staff member at our facility was trained for the stroke, and every new person who will be recruited to serve at our facility will be educated. Going forward, all our staff member will have a one hour educations every year going forward as a refresher. Next slide, please. Everybody has to be in. This is not limited to only clinical staff. Intake, liaison, case manager, our psychologist, our MDS, dietitians, everybody need to be in this game to help the patients. Obviously, clinical team is so important, and Dr. Harris and her team, they are fundamentally at the center of this care model. Next slide, please. Let's talk about education. So education is not only for our staff, education is so important, as I mentioned, about patients, resident, and family. Next slide, please. Okay. We want to educate them about primary disease, what impact it will have. We want to educate them about medications. More importantly, about complications. Our sole goal is to send them home, and they need to learn what kind of things that they need to watch for should the complications be happening, whether it's early or late in the game. They need to also follow through with the lifestyle management and risk factor management, such as hypertension, diabetes, hyperlipidemia, obesity habits, for the secondary preventions. Compliance is a huge thing. It is not easy to work with all these things with sudden life-changing event. From the rehab part, rehab education is also very important, and Dr. Harris will be happy to share her take onto this. Next slide, please. Okay. Let's talk about care coordination. This is a big chapter. Next slide, please. Care navigation. Before the patient comes to us, we really need to understand about patients. Once the patient is with us within 24 hours, we would like to have our every service provider visit the patient as best as possible. And we understand there are some challenges with the weekend. However, we want to do our best. Once the evaluation is done, we want to connect with the patients and family for the 72 hours goal. Our rehab team will start as early as 24 hours. Our social worker, case management, will work on from the day one for post-discharge, as well as understanding social determinant of the health need. Obviously, we will be very intensive in the clinical care. Next slide, please. Communications. Before patient comes, we really want patients and family and hospital system to know what kind of care we will be providing. So at the point of referral, we will share with them either in person, virtually, or through our case management. We will invite them to visit our facilities and understand how we will make difference in their recovery and in their life. Next slide, please. Okay. Next step, warm handoff. Warm handoff is a huge thing. Really coming with 100 pages of discharge, really is not easy way to read through, and everybody cannot do that. We truly are supportive of the warm handoff, and warm handoff needs to be done at 3 or 4 level: physician to physician, nurses to nurses, rehab team to rehab team, and case management to case management. And this is fundamentally very, very important, so we can have a patient-centered care plan. Next slide, please. Once we have plan in place, what we need to do and what we have been doing for 10 years is interdisciplinary team. It is the team that wins. So stroke team, everybody will work together, particularly rehab group of people. Patients face-to-face time is mostly with the rehab care provider, in addition to our clinical team. So we really keep our IDT in the center of our success. Usually it is led by Dr. Harris, physiatrist or neurologist, and we talked about triple goal. What are triple goals? Triple goal is patient's goal, how they want to get better, what they want to achieve. Physician's goal is about primary disease, comorbidities, early identifications, and then facility goal. Facility goal is about the length of stay, about what we want to achieve post-discharge downstream member, how we want to allow them to continue care, because our care is not the end point, it is a continuation. So our team remains in the center of our specialty program. Next slide, please. Social determinant of health. This was not very well understood till population health became popular last decade or so. We can do so good at hospital or nursing home level, post-acute level. However, it is a real life. We really need to understand people from inside out, about their housing, about transportations, about safety, family support. They lived this life for X number of years. How are we going to change this life? How are we going to make them most ideal patient? And how the disease process itself is changing their life. and how can they cope with it. Next slide, please. Okay. Let's talk about clinical management. Next slide, please. It's all about capabilities and resources. Fundamentally, our nurses, our CNA, our physicians, our rehab provider, they all need to improve their ability to provide specific care as it relates to stroke. Let me give you a couple of examples. Some of the stroke patients, as I mentioned, 1 in 5 aphasia, they cannot express very well. Their cognitive function is impaired because of the neurological damage. They may not grasp what you're trying to say that fast. So we really wanted to improve our capabilities of our service provider. Not only that, as I mentioned, we wanted to be prepared for any complications that should happen. So we are equipped with the EKG, bladder scanner, and IV capabilities, pain management. Our physiatrists can inject joint, can do a better pain management. Our psychologists and psych team can support patients and family. We will be always prepared to deal with any complications that may happen. So ultimately, this is what is going to improve process and outcome. Next slide, please. Process map. Just like our model, our process map is very simple, and however, it is very interwoven. Let's start with the patient's value. Ultimately, our goal is to create a patient's value. So first and foremost thing is we want to understand patients. We want to screen them. What is their educational background? What kind of counseling they will need? What kind of post-discharge help they will be needed? We certainly want to follow through our metrics, whether it is a process metrics or outcome metrics. All of you are very familiar with the discharge function score. Very importantly, we monitor number of the visits by every care provider, and we will follow, and we have been following stroke specific metrics. Our team is prepared and will be focused for the stroke related care. As we prepare, before patient comes, we do risk analysis. We establish triple goal. We do counseling with the family. As it relates to medical care, we will continue to monitor primary disease comorbidities, as well as we will closely work with consultations. One thing we did, we invited our hospitalist partner to come and work with us. We invited our specialists to come and be part of our team. And we invited our physiatrists to lead our rehab program. Rehab itself is a huge part of recovery as it relates to stroke. Not only just the rehabilitation, general rehabilitation, but the stroke specific rehabilitations, kind of combine them together. As I mentioned, rehab is not the end point. This will continue. Rehab recovery will continue up to 6 months or beyond. Family education is very important. They have a lot of expectations, and we also want to close all the loose end as it relates to rehab, whether it's an availability of equipment or restructuring in a patient's home. They may need to have a bathroom on the first floor. They may need to have easy access inside the home. So we really want to work everything in partnership with our rehab leaders. And ultimately, we want to manage through our IDT. We want to make progress and try to avoid any unplanned hospitalization as best as we can, because ultimately our goal is to create for the system, payers and community value, and value is an outcome divided by cost. So we need to do things right for the patients as well as for the providers. Next slide, please. Success. Our success secret is our specialty program lead. Every program is led by a person who really owns them. Before the patient comes, work inside. Once the patient is in, keep all the paperwork ready, work with our specialists, work with our rehab group, work with the family. We are really proud of our specialty program lead, and that's one of the key success, that they own it, they make things right. They also get the data together. They share with us data and allow us to find out where we need to get better or where we are falling out. They do monthly scorecard for the process metrics and outcome metrics, share with our specialists, share with our entire medical staff. This is how we get better. Next slide, please. Finally, performance improvement. We really have to be honest to ourselves. Next slide, please. We have a set process metrics that we want to follow through and outcome. Obviously, unplanned hospitalization is a huge thing. From the CMS standpoint, UPS means poor care. And we certainly, if we do things right, we certainly can help improve unplanned hospitalizations. From the clinical standpoint, this is our great opportunity between 2 to 4 week stay about utilizations of medications, optimizing medications, educating them, providing them appropriate instructions. Also, give them opportunity to talk about if there is necessity about serious illness and advanced care planning, as well as work with them about medications. We share all these metrics with our hospital partners, as well as the downstream partners, and we really want to keep on getting better for the best. Next slide, please. QAPI. Okay. I like PI. The performance improvement is in the center of how we can get better for the future. Okay. We follow through our scorecard. We share with everyone. We follow critical element pathway, which is a huge part of our specialty program. All of you are familiar. 2025 is going to be, team is going to be a huge word. So team is about specific disease, accountability, and measured approach. And we're going to follow through stroke as one of our team approach. Next slide, please. At this time, I'm going to invite Dr. Tracy Harris to share her side of the story, how important the rehab part is in the stroke recovery. Dr. Harris.
Hello, good afternoon, everyone. Thank you, Dr. Varoja. I'm here to present my part of the webinar, which will discuss stroke recovery and physical medicine and rehabilitation. If you can go to the next slide. So advanced subacute care and targeted stroke rehabilitation programs represent the next phase in post-acute recovery, and ideally is guided by an interdisciplinary team, which should include therapy services along with outcomes management / social work services, and led by PM&R specialists to assist the primary care providers with the everyday care of the patients. Next slide. Part of that interdisciplinary team includes rehab nursing services, as I said, physical therapy, occupational therapy, speech and language pathology, recreation therapy, nutrition services, counseling, social work, psychiatry and psychology, as well as the important patient and family education, as these patients are discharged to home and need to have an idea of how to function in the community once they've completed their rehab stay. Next slide. In general, stroke rehabilitation should include, at minimum, training to improve mobility and ability to do the everyday tasks of daily living, tailored post-stroke exercise program. The patient should have access to cognitive and engagement activities for our cognitive patients, speech therapy when that is clinically indicated, along with exercises to improve their vision, as that is a significant component to mobility when that is clinically indicated, adaptive strategies to help them function within a new normal, as not all, but some stroke patients do not regain full recovery even after completing a comprehensive rehabilitation program. Next slide, please. So I outlined in the next several slides the different roles of the different therapy services: physical therapy, occupational therapy, and speech and language pathology. So we'll start with physical therapy. Physical therapy team is mainly there for mobility training, which includes bed mobility, transfers, which means having the patients transfer from one surface to another. That could be from sitting to standing, that could be from bed to wheelchair, or from the wheelchair to a car. They also assist with stair and curb negotiation as well as wheelchair management. They provide therapeutic exercises and activities to help promote neuromuscular re-education and return for the patients, passive and active range of motion for the hemiparetic upper and lower extremity, with physical therapy mostly focusing on the lower extremity and occupational therapy mostly focusing on the upper extremity. They also reinforce the strategies for fall prevention and safety strategies with the family as well as the patients. Another key component where physiatry is directly involved on a regular basis is the fitting of orthotics, which would be bracing for patients, particularly the hemiparetic patients that may need a brace for their ankle or knee to improve their stability and ability to ambulate or transfer upon discharge, as well as providing recommendations for durable medical equipment, meaning hospital beds, a walker, wheelchair, whatever equipment the patient needs to be as independent as they can in the community. Patient and family caregiver education is also a significant part of the therapy process, and the patient's families are often encouraged to come in to participate with therapy services prior to the patient being discharged to home. Next slide, please. Occupational therapy focuses on the everyday skills like bathing, dressing, grooming, doing things in the kitchen, the things that we take for granted on a daily basis, but after suffering a stroke or neurological injury, often have to be retrained or modified for the patient's new deficits, taking into account that they may have a weakness on their dominant side, which they did not have before. So occupational therapy focuses on self-care skills and often includes the use of adaptive equipment, providing the patients training with hemi dressing techniques and task modification in order to improve energy conservation with performing these tasks. They work on adapting their environment. For example, if a patient has some type of visual deficit and does not see to the left, they encourage and teach the family and the patient along with the staff that things maybe need to be put on the right side so that the patients are able to access them. Once the patients get closer to discharge, some occupational therapists can provide suggestions with work task analysis and then recommendations about returning to driving and the different opportunities that are available for patients to educate themselves on that. As Dr. Varoja spoke, that oftentimes there's home modifications that are required, and occupational therapy, along with physical therapy and the physiatrists, are able to make recommendations to the family and the patients about what those modifications may be. And occupational therapy also focuses on upper extremity weakness and return of motor strength involving the use of electrical stimulation, splinting, and desensitization techniques, including vibration and kinesiotaping. Next slide, please. Speech and language pathology focuses on, as it says, speech and language. Speech being the patient's ability to articulate, language being the patient's ability to either understand or communicate. They also focus on swallowing strategies. So their therapy includes dysarthria, teaching management of aphasia, cognitive evaluations and treatment, dysphonia, and dysphagia. They target areas of impaired cognition through the use of compensatory strategies, and they also provide exercises to increase the strength of the patient's vocal cords for a patient that might have hypophonia or not be able to express themselves from a tone standpoint. Speech and language pathology also works with swallowing, as I said. They provide exercises to help strengthen the patient's swallowing muscles, along with guidance with upgrading their diet when clinically appropriate in order to decrease the risk of aspiration and aspiration pneumonia. Next slide, please. So our program is designed to enhance the functional recovery and focus on mobility, communication, and independence to improve the overall quality of life for our patients. Our key services are listed there and are dedicated. We have a dedicated unit where the rooms provide specific adaptive equipment and modifications to the room based on what the patient's individual needs may be. Our nursing staff delivers structured education, ensuring patients and caregivers understand stroke recovery, secondary prevention, and then provide strategies for long-term care management after the patients are discharged. Some of the specialized features that we utilize would be the LifeGate, which is a system that supports weight-bearing status to improve ambulation and neuromuscular return and re-education. We also provide Synchrony, which is a biofeedback-driven tool to enhance speech and swallowing therapy for our post-stroke dysphagia patients. Our care plans are tailored based on stroke severity, the neurological deficits that the patient is demonstrating, and patient-specific recovery goals. And our physicians collaborate with the patients on risk factor modification, management of their blood pressure, anticoagulation management, lifestyle interventions, and adherence to all the evidence-based guidelines. Our program benefits include utilizing the latest stroke rehab protocols and integration of early mobilization strategies and multidisciplinary interventions to optimize our functional outcomes. Our personalized rehabilitation plans are designed to restore motor function, improve cognition, communication based on specific patient needs. We focus on return to home readiness, including the patient being as independent as they can with their activities of daily living, mobility, and self-care independence. And we provide a structured education sessions on stroke recovery, risk factor management, and secondary prevention. And then also encourage the patients to participate in a post-rehab stroke support group to assist them with transitioning back to the community. Next slide, please. I've included 2 case studies which demonstrate our success. This first one was a 60-year-old patient who presented with a left stroke, ended up with an endarterectomy. When the patient presented to us, the patient was requiring moderate assistance for their activities of daily living, which means about 50% of the help was provided by our occupational therapy staff, and the patient was doing about 50% of the work. And they required about minimal assistance for their functional mobility, meaning walking, transfers, bed mobility, etc. The patient's goals were to be independent and go back home with his wife and son. And the patient indeed did achieve those goals and was modified independent for self-care and was ambulating with a single point cane at discharge. Next slide, please. And this is another example of the success of our post-stroke recovery program. We had a patient who presented with a right CVA with residual left hemiparesis. He was transferred to our facility for post-stroke recovery under the management of Dr. Balampali, who is a geriatrician in charge of his care, as well as my team, which includes myself, 2 other physiatrists, and we have a physician's assistant that works with us. When the patient presented to our facility, the patient was moderate assistance for their self-care and for ambulation. Their goal upon discharge was to be able to go back to work and to go home with their family. And this patient indeed as well was able to be independent. Thank you.
Thank you, Dr. Harris. Steve, would you kindly share your take about importance of certification as it relates to patients, as it relates to healthcare system, and as it relates to payers, community? Thank you.
Sure, Dr. Baroja, and I'll ask you the question at the end as to why you all chose to pursue this. But next slide. I'm not going to go through every single bullet point because we're limited on time, but I really want to speak to the people that are on this call because I think this is key, I'm going to reiterate, the importance from a system of care perspective, but most importantly from a patient perspective. So for our hospital partners that are on this call, many of you are either certified, your hospital certified for acute care for stroke, or you're doing our Get With the Guidelines quality program, our Get With the Guidelines stroke quality program. And That journey began, a little over 20 years ago. The first actually certified hospital in the United States on the hospital side was in 2004, a little over 20 years ago, coming up on 21 years. But if you think about all that you do from a hospital perspective, and the importance of quality outcomes for your patients, a system of care doesn't end when you discharge the patient. And I can't express enough, especially Dr. Harris, who works with the virtual health system, and especially Mount Holly, who has a very close working relationship with them, that if you are having a stroke in that New Jersey area, the whole thing is this is where it doesn't just, end at when you get to the hospital, that this high quality of care, which, is exemplified and validated through the post-acute certification, continues along that journey through the post-acute space. So for those hospital partners, we would highly encourage you throughout the country to, approach your SNFs that you are working with, ask them to, take the next step in pursuing certification for this, because as you can see, it's a very structured program. And then not only will you have a comfort level if the patient, goes to the skilled nursing level of care, but go to the next slide. This is and can go to the next slide. But this is where, from a patient perspective, this is where they can actually have confidence. If you look in the very lower left-hand corner of the slide itself, every site that in our post-acute space that gets certified gets to utilize this logo that includes the heart check mark for patients or family members that are making a choice of where to go. This provides comfort to them that the American Heart Association is validating and backing the care that is provided at this site in the post-acute entity. And this is what really fosters that confidence in that system of care approach. Because if the patient ultimately is going to a suboptimal facility, then can we expect the same outcomes? And that's where, again, that's why we would highly encourage the skilled nursing facilities to take the next step along this journey. And part of that, and again, is then working with us, working with your hospital partners, really to connect the dots and foster that system of care approach, because that's what ultimately is going to lead to all the success that is being demonstrated here today on this webinar, and the success that we're going to have, down the road in the future from an entire stroke perspective. Next slide. Again, the improvement of this, leads to, easier, let's just say easier choices, better quality of life. That's what we're all striving for, whether it's the skilled nursing providers on here or the hospital providers. We want the patient to be able to walk back into the hospital, for their follow-up visit. And like I said, the key word there is be able to walk back in, with reduced deficits and so on. Everybody, along this continuum of care is striving for the same thing, the best outcomes for the patient, and this is where Dr. Harris and Dr. Varojaa really have exemplified their desire and their passion for this. And this is what we need to continue to do, to drive facilities to pursue this and connect the dots between our existing hospital partners and these facilities to improve the care overall. Next slide. And as this is a slide that Dr. Varojah put in here. Again, disease-specific care, one team, one plan, one standard, and one spectrum is so important. It's a model that Marquis has taken on, in working with Virtua and all the care that is being provided really is what is going to lead us into the future. Go to the next slide. And before I ask Dr. Varojah that key question, next slide. I really wanted to remind everybody that please submit questions into the Q&A, and we'll have about 5 minutes. But while we're waiting for the questions, anybody that's interested in pursuing the stroke rehab certification, please reach out to us. You can email us. There's also going to be a follow-up survey with prompting you to do this. And again, I would encourage you, the hospitals, to work with your skilled nursing partners to introduce them to this if they're not aware, and to encourage them to pursue this. If you are attending our International Stroke Conference, which is coming up next week, I would encourage you to stop by our VIP lounge in the exhibit hall, and we have what is called a mentoring corner, and stop by, for a special gift and get any questions or advice answered. So the first question, going back to Dr. Varojah, is why did you choose to pursue AHA certification?
Okay. It is about validation of our vision, our mission. Really, we had a great vision from 2014 till 2020. What we realized that partnering with American Heart Association, getting additional steam, additional power to our program made a huge difference in our heart failure care. We are serving probably in the range of 4,000 heart failure patients at 35 facilities, and our outcome have improved. So as we think, again, it has to be one disease, one spectrum, standardizations, getting rid of the variability, keeping team together where we have specialty lead person owning this process and specialty medical director, specialist contributing is a huge difference. Really, we were not getting anywhere with the heart failure in 2014, and hospital realized that 1 in 4 patients, 25% of the heart failure people were coming back. Same thing about stroke. Stroke is another long-standing disease and making people at risk of unplanned hospitalizations, recurrent hospital, and devastating impact. Just for that reason, we strongly believe that we need to do things right, and it's not about only us. We all need to be in this game together, and that's why I say that it is one spectrum. And I truly believe that we are improving care through certifications. We are elevating ourselves, we are challenging ourselves, and hoping to spread this word throughout the country to make a bigger difference. Thank you, Steve.
Thank you. Dr. Harris, being that you're with the Virtua Health System, and I know that you also serve as the physiatrist for an inpatient rehab facility, why is it so important, especially because not everybody can go to inpatient rehab? Why is it so important for skilled nursing facilities to move forward with having a disease-specific stroke rehab program?
Hi, Steve. I think you sort of answered the question in the question. There are patients that can't either tolerate acute inpatient rehab, because acute inpatient rehab has its own requirements for patients to be admitted. They do meet the diagnosis requirement oftentimes, but sometimes they do not meet the ability to tolerate the acute inpatient level of rehab, and they need to transition to a lower level of rehab. Or we have patients that do come to acute rehab, they make a little bit of progress, but they still need additional time, and then they're transitioned to the subacute level of rehab. So I think there's especially in this area, and with virtual Our Lady of Lourdes being, and virtual Mount Holly having such a large neuro population, I think there were a lot of patients that were skipping over the acute rehab component and going directly to subacute rehab. And I think it provides a significant confidence, not only for the families, the patients, and the caregivers, that we have a program that is able to, not that we can duplicate what's being done, but provide the appropriate services that are being led by a team that also work in the acute care setting. So we're bringing our knowledge and expertise to that setting to hopefully transition the patients to functional independence, even though it may take them a little bit longer to do it than if they were to transition directly from the hospital into an acute care inpatient rehab.
I believe we are at time. I can't thank you, Dr. Ferroggia and Dr. Harris, enough for your phenomenal presentation and your expertise. I want to thank all our participants on the call. Again, I would encourage you immediately hereafter. There's going to be a survey sent to you. Please, answer those questions, as it helps us for future webinars. And also there will be a follow-up email that will be sent to you, I believe tomorrow, with a certificate of attendance and some additional information, and the recording. Again, thanks to all that joined us today, and have a great day.
Thank you all.
Thank you, everyone.
Thanks.
Thank you, Steve.